화면 보이시나요?
네, 보입니다.
네, 발표 시작하겠습니다. Good morning, I'm Jian Jung from Gangnam 7 Hospital. Today, I'd like to present you about the comparison of survival after gastrectomy with or without aberrant left hepatic artery preservation in gastric cancer patients with metastatic lymph node. Radical gastrectomy is still the main curative therapy for gastric cancer. According to the Japanese guideline, standard gastrectomy involves resection of at least 2/3 of the stomach with the D2 lymph node dissection. In principle, D2 lymphadenectomy is indicated for clinically metastatic node or T2 or deeper tumors, and a D1 or D1 plus lymphadenectomy for clinically T1 and 0 tumors.
정진
Anyway.
선생님 죄송한데요. 발표
네.
화면이 공유된 화면이 자막으로 나온 슬라이드
오.
공유가 되고 있어서
네.
공유 화면을 선택을 다른 걸로 해주시면 좋겠습니다.
아, 네. 죄송합니다. 이제 보이시나요?
지금도 저기 자막으로 보이는데요.
네.
아니면 잘 안 되시면은 원래
네.
슬라이드 쇼 발표하지 말고 그냥 슬라이드로 화면 조금 키워서 발표하시는 게 나을 것 같아요.
아, 네. 계속하겠습니다. Anyway, as you could see in this picture, you must dissect lymph nodes around celiac axis, whether subtotal or total gastrectomy for stomach cancer patients. During gastrectomy, hepatic artery variations are occasionally seen. Approximately 20 to 30% of variations are aberrant left hepatic artery arising from the left gastric artery. This Michel's classification, which is the most widely used system, shows variable hepatic artery anomalies, including normal anatomy. Aberrant left hepatic artery is classified as either a replaced artery, which is a substitute for a normal left hepatic artery, or an accessory artery, which is present in addition to the normal artery. Radical gastrectomy for gastric cancer is required to ligate the left gastric artery at the root level to ensure lymph node dissection, and the existing aberrant left hepatic artery will inevitably be sacrificed. However, the ligation of aberrant left hepatic artery may cause liver ischemia and severe postoperative complications, such as left hepatic lobe necrosis and liver dysfunction, because part of the liver may be supplied by this artery. So, some literature recommend preservation of aberrant left hepatic artery during surgery, especially in patients with pre-existing liver disease, to prevent liver dysfunction and ischemia. But it is technically challenging to completely remove lymph nodes surrounding aberrant left hepatic artery. Several studies have been conducted about aberrant left hepatic artery preservation and liver function. This study was performed in Japan. From January 1985 to June 1991, 141 patients were enrolled who underwent postoperative angiography and radical gastrectomy for gastric cancer. 28 patients were identified aberrant left hepatic artery, 13 were preserved, and 15 were sacrificed. Liver function was evaluated. LDH, GOT, and GPT levels were peaked on the first post-operative day in all groups.
현장에서는 가입을 잘 안 하시는데 저희가 가입 시간을 보니까 교육 끝나고 나서 가입하시는 분들이 금요일날, 수요일날 가입하시는 분들이 있습니다.
The change was greatest in aberrant left hepatic artery sacrifice group, and there was a significant difference in OTPT level changes between aberrant left hepatic artery preserved and sacrificed group. They also compared the relation between the aberrant left hepatic artery feeding area and postoperative liver function in sacrificed group. The greatest change was noted in patients with a large replaced aberrant left hepatic artery, which feed the lateral and medial segments of liver. Every patient's liver function normalization was seen after 1 week from the surgery. So the author concluded that sacrificing aberrant left hepatic artery does not cause severe liver damage in most patients. This study also conducted at Japan from March 1997 to September 2001. Data of 50 gastric cancer patients with aberrant left hepatic artery were collected. Their operative feasibility and postoperative liver function were analyzed. The extent of total nodal dissection was greater in the aberrant left hepatic artery divided group than in the preserved group. However, the number of lymph nodes dissected around the left gastric artery per patient was comparable between the two groups. Similarly, there was no significant difference between the two groups in the total number of metastatic lymph nodes and the number around the left gastric artery. Severe changes of serum liver enzyme after surgery are presented in this figure. Levels of AST/ALT on postoperative day 1 and 3 were significantly higher in the aberrant left hepatic artery divided group than in the preserved group. LDH on postoperative day 1 was higher in the aberrant left hepatic artery divided group than in the preserved group. A gradual decrease in liver enzyme was observed at the peak level with recovery to the reference range within 7 to 10 days in each group. In this study, there was no difference in the therapeutic effects of lymph node dissection around the left gastric artery between two groups. And preserving the aberrant left hepatic artery may be able to obviate postoperative liver dysfunction. So the author suggested that at curative gastrectomy for gastric cancer, routine division of the aberrant hepatic artery does not be required as long as it is not directly involved by the tumor. This study was performed in Korea about laparoscopic gastrectomy patients with aberrant left hepatic artery. Data of 150 patients were collected. The median number of the lymph nodes retrieved was comparable in both groups. This study also evaluated the diameter of left gastric artery on preoperative CT to correlate the postoperative liver enzyme levels. The median diameter of the left gastric artery was 4.6 mm in the aberrant left hepatic artery ligated group and 5.1 mm in the aberrant left hepatic artery preserved group, which shows significant differences. There were significant differences between the groups in terms of AST and ALT levels on postoperative day 1. In subgroup analysis of the aberrant left hepatic artery ligated group, the diameter of the left gastric artery correlated positively with elevated liver enzyme on postoperative day 1. The linear regression analysis shows an aberrant left hepatic artery rising from on left gastric artery larger than 5 mm in diameter should be preserved to avoid post-liver enzyme elevation. So the author concluded to preserve aberrant left hepatic artery arising from a large left gastric artery diameter larger than 5 mm during laparoscopic gastrectomy to prevent immediate post-hepatic dysfunction. There is still controversy regarding whether aberrant left hepatic artery should be ligated and whether liver dysfunction occurs when aberrant left hepatic artery is ligated. In the systematic review in 5 studies, the researchers strongly recommended that preserving aberrant left hepatic artery could reduce postoperative complications. In the other 4 studies, the researchers reported that there was no significant differences in the change in liver function between the aberrant left hepatic artery ligated group and the preserved group. But most studies recommend preserving aberrant left hepatic artery for protecting liver function. There was lack of evidences about long-term outcomes, and it is also questionable whether aberrant left hepatic artery preservation will ensure oncological safety in the case of advanced gastric cancer patients or clinically metastatic lymph nodes. Aberrant left hepatic artery preservation is of good concern to surgeons regarding patients' postoperative liver function, safety, and oncologic outcomes. So we plan to compare the survival between the aberrant hepatic artery preserved and sacrificed group in gastric cancer patients who have metastatic lymph nodes to confirm oncologic safety. Medical records of patients who underwent curative gastrectomy for gastric adenocarcinoma at Severance and Gangnam Severance Hospital from January 2006 and December 2021 was reviewed. The presence of aberrant left hepatic artery was confirmed during operation. The preservation was recorded on the operation record sheet. If an aberrant left hepatic artery was encountered during dissection of the gastrohepatic ligament, and if it were to be preserved, fat and lymphoid tissues around the entire course of the vessel were skeletonized during dissection and then ligated distal to the branching from the left gastric artery. And if aberrant left hepatic artery were to be sacrificed, left gastric artery was ligated at root of the vessel. Patients who pathologically confirmed with metastatic lymph nodes only included for this study, and stage 4 patients were excluded. Here's the results. 540 patients were included. Aberrant left hepatic artery was preserved in 187 patients and sacrificed in 353 patients. Though significant differences were seen among 2 groups in terms of age, gender, and lymph node dissection range. More patients underwent total gastrectomy in the aberrant left hepatic artery sacrificed group than in the preserved group, which shows significant difference. In addition, there was more patients with higher end stage in aberrant left hepatic artery sacrificed group, which results in higher TNM stage with statistical difference. Until the last follow-up period of each patient were compared, there was no difference between the 2 groups in survival and recurrence. The operation data are in this table. The mean operation time was just a little bit longer in preserved group. However, there was no statistically difference between the groups. The total number of dissected lymph nodes and the number of dissected lymph nodes around left gastric artery, which consisted of lymph nodes at the right paracardial, number 1, and along the celiac axis, number 7, 8, and 9, were analyzed separately. The total number of lymph nodes and lymph nodes dissected around the left gastric artery per patient were comparable between the 2 groups. Meanwhile, the pathological stage of disease in the aberrant left hepatic artery sacrificed group was relatively advanced compared with the preserved group, which results in statistical significance in the mean total number of metastatic lymph nodes. The overall 5-year survival rate after surgery in the aberrant left hepatic artery preserved group was 19.4% versus 19.8% in the sacrificed group. Also, there was no significant difference in the analyzed by stage. In addition, the recurrence-free survival rate showed similar results between groups. The recurrence pattern of both groups were comparable. Around 30% of each group patients had recurrence. The most frequent recurrent site was peritoneal carcinomatosis, followed by para-aortic lymph nodes. In summary, there was no differences in the operation time and the number of harvested lymph nodes around the left gastric artery between the aberrant left hepatic artery preserved and sacrificed groups. Therefore, it is not necessary for surgeon to divide aberrant left hepatic artery for the purpose of lymph node dissection unless there are obvious signs of tumor metastasis. Also, overall survival and recurrence-free survival were comparable in two groups. In conclusion, aberrant left hepatic artery preservation could be performed safely in terms of long-term recurrence and survival for gastric cancer patients with clinically metastatic lymph nodes. Preoperative CT imaging or intraoperative ICG injection for inspecting liver perfusion could be helpful for identifying aberrant left hepatic artery type, whether replaced or accessory, and its territory. In our study, the pathological stage of disease in the aberrant left hepatic artery sacrifice group was relatively advanced compared with the aberrant left hepatic artery preserved group. So propensity scoring and further prospective researches are required to confirm the oncologic safety of aberrant left hepatic artery preservation. Thank you for your attention.
네, 정지훈 선생님 발표 감사합니다. 그 발표 주신 내용에 대해서 질문 있으신 선생님들 질문 부탁드리고요. 우리 전공의 선생님도 많이 참석해 주셨는데 전공의 선생님들 중에서도 평소에 궁금했던 거 있으면 편하게 디스커션 하시면 좋겠습니다.
May I have questions?
Yes.
Thank you very much for your very nice presentation, very interesting topics. So I really enjoyed your talk. My question, I have two questions. Number one question is that your group performed two types of surgery according to the aberrant left hepatic artery. Sacrificing approach and preserving approach. What was the indications whether you preserve or sacrifice the left gastric artery in your cohort? And number two question is that you showed us the result showing that aberrant left hepatic artery sacrificing approach result in a much more number of lymph node metastasis, lymph node retrieval numbers. So, in my opinions, although of course you have already showed us the comparable survival outcome between two groups according to the stage, but in my opinions, when you analyze the data according to the lymph node metastasis, maybe the lymph node sacrificing group might result in a better survival because it can provide a much more number of lymph node metastasis according to your result. So have you ever tried to analyze the survival outcomes according to the lymph node metastasis between two groups? That is my question.
Thank you for your question. And the first question, 한국말로 대답해도 될까요, 교수님?
네, 말씀하시죠.
먼저 sacrifice랑 preservation 기준에 대해서 여쭤봐 주셨는데, 그거는 약간 프리업 CT상에서 replaced 타입이거나 한 경우에는 preservation을 했던 것 같고, 그 aberrant hepatic artery 주변으로 림프노드 메타스타시스가 있는 경우나 좀 더 어드밴스된 케이스 같은 경우에는 sacrifice를 했던 것 같은데, 이전에나 신촌에서는 어떻게 진행을 했는지는 정확하게 수술 기록지에 기록된 바는 없어서 제가 이제 평소에 들어갔던 수술에서는 그렇게 진행을 했던 것 같습니다. 그리고 두 번째 질문 주셨던 거에 대해서는 여기 결과를 보시면 sacrifice 그룹이랑 preserved 그룹에서 림프노드 디섹션 개수는 크게 차이는 없었고 sacrifice 그룹에서 이제 메타스타틱 림프노드가 좀 더 많이 획득된 거를 확인할 수가 있는데 이거는 이제 sacrifice 그룹에서 이제 좀 더 엔스테이지가 진행된 환자가 더 많이 포함되어 있어서 그랬던 것 같고 이거에 대해서는 제가 생각하기에도 프로펜시티 스코어 매칭 같은 걸 통해서 조금 더 보정을 해서 서바이벌이나 리커런스를 좀 더 비교를 해봐야 한다고 생각합니다.
이제 권인규 교수님
네.
부탁드리겠습니다.
네, 저희가 사실 어브런트 헤파티가터리가 뭐 10에서 20% 정도 흔하게 수술하다가 만나게 되는데 사실 세크리파이스하고 프리저베이션 하는 절대적인 기준이 없고요. 당연히 뭐 사이즈, 스테이지 이런 것들을 고려해서 결정을 하게 되는데 보통 리플레이스 타입이면 저희가 아무래도 리버 펑션이 걱정이 되기 때문에 프리저브를 하려고 노력은 하는데 사실은 온콜로직한 게 더 중요하다고 생각해서 사실 진행이 많이 되고 노드가 그 주변으로 메타스타틱 노드로 의심되는 노드가 있으면 뭐 어쩔 수 없이 쇼텀 아웃컴 포기하더라도 세크리파이스 하는 경우들도 많이 있습니다. 그래서 절대적인 기준이 있는 건 아니고요. 그때그때 상황에 맞춰서 뭐 결정을 해야 되는 거고 이게 뭐 지금까지의 데이터를 보면 세크리파이스에도 보통은 뭐 크게 문제가 없다라는 게 사실은 더 많긴 하지만 사실 흔하지 않은 컴플리케이션이 걱정되는 건 뭐 여전을 해서 사실 프리저브 할 수 있으면 프리저브 하려고 사실 서전들도 많이 노력을 하고 있고요. 그래서 결과를 보면 림프노드 개수는 크게 차이가 없다라는 뭐 데이터들이 많긴 하지만 사실 롱텀 아웃컴에 대해서는 이렇게 많은 환자들을 대상으로 이제 분석을 해본 적이 없었던 것 같고 그래서 데이터상으로 서바이벌을 보여주는 데이터는 아직까지 없었습니다. 지금 분석하고 있는 거는 아직 저희가 준비 기간이 조금 짧았어 가지고 매칭 같은 걸 하지 못해서 이제 영어로 이제 질문하신 것들처럼 스테이지나 이런 것들이 뭐 같을 수가 없고 진행이 많이 될수록 세크리파이스 하는 경향들이 아무래도 더 많기 때문에 지금 데이터상에서 좀 차이가 나는데 프로펜시티 매칭을 하고 해서 하면 아마 조금 결과가 보완되지 않을까 생각하고 있습니다.
호진입니다. 저희가 세크리파이스 하는 경우하고 하지 않는 경우는 제일 근본적으로는 아나토미칼리 말씀을 드리면 세그먼트 4로 가는 베슬이 있느냐 없느냐가 되게 중요하고요. 세그먼트 4로 가는 베슬이 있으면 리플레이스라고 할지라도 잡아도 크게 데미지를 입지는 않는 것 같습니다. 그런데 이 컴플리트 리플레이스먼트이면 사실 몇 개의 케이스 리포트들이 있는데 리버의 레프트 로브에 임팍션이 엄청나게 오고 경우에 따라서는 환자가 모탈리티 난 것에 대한 케이스 리포트도 뭐 1960년대쯤에 있었던 것 같아요. 그래서 이제 가능하면 살릴 수 있으면 좋은데 특히 셀리아엑스의 노드가 컨글러메이션 돼 있는 경우에 프리저베이션 하려고 그러면 메타스타틱 노드가 인텍트하게 리섹션 되기가 사실 테크니컬리 그렇게 쉽지 않습니다. 그렇게 되면 노드가 깨지거나 수술 중에 깨지거나 하게 되면 이게 온콜로지컬한 프린시플이 문제가 되는 부분이어서 그런 부분들을 고려해서 잡은 경우도 있었는데 제가 제 경험대로 말씀을 드리면 한 서너 번 정도에 걸쳐서 리버에 임박이 오고 그냥 임박만 왔으면 괜찮은데 앱세스까지 간 경우도 2번 있었고요. 그래서 사실은 어떻게 기준을 잡느냐가 되게 중요한데 최근에는 RCG가 있어서 인트라옵에 뭐 라파로스코피나 로봇을 하는 경우는 RCG 인젝션하고 랩틀롭으로 블러드 플로우가 가는 걸과 확인이 되면 별 생각 안 하고 잡을 수도 있고 사실은 수술 시간이 별로 차이가 안 났다 그러지만 사실 서전이 그 조그만 베슬들 다 찾아가면서 살리고 이렇게 하는 거 사실 쉽지 않거든요. 이게 수술 뒤쪽에서 일어나는 일이어서 그래서 가능하면 그냥 괜찮다 싶으면 잡고요. 그런데 정말 랩틀롭으로 안 가면 가능하면 살리려고 그러고 최근에 저희가 어드밴스 캔서가 그리 많지 않아서 그렇고 아마 최근에 있는 케이스들이 더 많이 살려져 있어서 이게 그 서바이벌의 컴패리슨에 수술 시기가 조금 프로펜시티 할 때 매칭이 돼야 될 부분이 일부 있을 것 같습니다. 그런 부분들에 대한 고려는 조금 해주셨으면 좋겠어요. 괜찮은 토픽이고 잘만 분석하면 좋은 결과가 나올 수 있을 것 같은데 양쪽 그룹 간의 서바이벌이 지금 되게 높게 나오는 거는 아마 제가 보기에는 팔로업이 너무 짧아서 그럴 것 같기는 한데 왜냐면 이게 보니까 NCD 막 이런 환자가 상당히 많음에도 불구하고 서바이벌이 엄청 좋잖아요. 이게 아마 렐러티블리 최근에 팔로우하는 환자들이 많아서일 거고 저희 그 수술지 양식이 바뀐 게 한참 지나서였어서 아마 그런 부분들에 대해서 조금 한 번만 더 고민하시고 분석하시면 좋은 결과 낼 수 있지 않을까 싶습니다.
코멘트 감사합니다.
하나만 그냥 간단한 질문 하나만 드리겠습니다. 그러면 이건 복강경 한 거랑은 차이가 없어요? 복강경 한 거랑 오픈한 거랑
그 수술 기법에 대해서는 추가적인 분석은 해보지 않았는데, 그 수술 기법도 나눠서 한번 분석해 보도록 하겠습니다.
예, 감사합니다.
네,
의사서
감사합니다.
말씀하신 차이가 조금 있을 수 있을 겁니다. 어드밴스 캔서라면
그러니까
예, 그 7번 쪽에 노드가 막 컨글러메이션 돼 있는 경우에 또 잡은 경우가 있었는데
예,
그거 다 오픈했을 때였고요.
그렇죠.
라파로스코프 초창기에는 특히 라파로스코프에 어드밴스 캔서를 안 했었기 때문에 수술을 더더욱이 아마 그런 바이어스는 분명히 있을 가능성이 있습니다.
예, 감사합니다.
네, 감사합니다. 그 채팅창에 두 강사 선생님 그 발표 평가가 있으니 다시 한번 확인해 주시고요. 네, 더 질문 없으시면은 이상으로 10월 17일 리서치 세미나 종결하도록 하겠습니다. 감사합니다.